published in, sorry, I just saw something popping up on my screen. Oops, sorry, reset my presentation. There we go. Can everyone see the slides?
Yes.
Okay, perfect. So in terms of the value of an early lupus diagnosis, there was a retrospective claims analysis done on a commercial claims database, starting out with patients who were diagnosed with lupus, and then taking a look backwards in time through their EMR records to ascertain those patients who received an early diagnosis, defined as within 6 months of onset of their symptoms, versus those patients diagnosed more than 6 months removed from the onset of their symptoms. And when you stratify these lupus patients according to this early diagnosis metric, what you find is that those patients who received an early diagnosis tended to have improved outcomes. And in lupus, what that commonly means is these patients had fewer flares. When they did flare, they were less severe. And as you would expect, they tended to have lower rates of hospitalization and specifically reduced damage as defined by the SLIC damage index that's been commonly used in many lupus trials. And then in addition to these improved outcomes, what you see is that because these patients are not requiring hospitalization or even emergency room visits as frequently as the patients with later diagnosis, the total cost of care for these patients in terms of direct medical costs were significantly reduced, underscoring the significant opportunity that exists for a better diagnostic marker to shorten the length of time it takes to achieve a definitive diagnosis of lupus. On this next slide, this is a study that was published again in A&R back in 2018, highlighting the fact that while lupus is a relatively uncommon disease, with epidemiology studies placing it somewhere between 200,000 and 500,000 Americans in terms of the total population, it's a significant killer of particularly young women with chronic inflammatory disease, and certainly a leading cause of death amongst African American and Hispanic females, which tend to experience a more severe form of lupus than white patients diagnosed with lupus. And in terms of leading causes of death amongst women between 10 to 44 years, it's in the top 15 causes of death. So again, significant opportunity to improve outcomes in a population that has been largely underserved by the diagnostic tests currently available. So we have a little video here that explains our cell-bound complement activation products, our proprietary biomarkers, and how that differs from your conventional approach of measuring C3 and C4. So briefly, we primarily test 3 types of CB caps on erythrocytes, that's our EC40, B lymphocytes, as well as platelets. And we'll talk about in the slides that follow sort of the different roles of these biomarkers in the diagnosis and prognosis of lupus.
The classical complement pathway plays an important role in the immune system of a healthy person, helping to avoid illness. Its key function is to trigger an immune response after antibodies detect microbes and damaged cells, as pictured here. After the C1QRS complex binds to the antibodies, a cascade of enzymatic reactions consumes circulating complement proteins. In SLE, this pathway is believed to play a pathogenic role, and excessive activation is associated with disease activity. C3 and C4 originate from the liver and are commonly measured for insight into SLE disease activity. However, this approach suffers from several factors, including changes in the amounts produced by the liver, increases caused by acute phase inflammation, individual variability. This explains why relying on C3 and C4 levels alone can be suboptimal for SLE assessment. In a person with SLE, this system is imbalanced and autoantibodies form against non-threatening cells and molecules. Fortunately, there is a way to measure this dysregulation. When bound to a host cell, like this B cell, An important protective reaction occurs, creating IC4B. This terminal action sheds off C4C, sparing the cell and leaving C4D attached for the remainder of the cell's life through a covalent bond. Measuring these cell-bound complement activation products, or CB-CAPs, provide valuable information to aid the diagnosis, prognosis, and monitoring of SLE. Studies in conjunction with leading national institutions have demonstrated that the combination of EC4D and BC4D outperforms the measurement of C3 and C4 by 22% in the detection of SLE. Furthermore, a significant association has been demonstrated between EC4D and SLE disease activity. The most recent CB-CAPS discovery explores how complement activation in the artery or veins may signal risk of thrombosis. Here we can see C4D being deposited on platelets, creating PC4D. Elevated levels of PC4D have been shown to have a significant association with the history of thrombosis in SLE. This scientific breakthrough allows for better patient care through the diagnosis, prognosis, and monitoring of autoimmune diseases. Discover what CB-CAPS can do for your patients today. Learn more at avisetest.com.
So hopefully that video provided a little bit of context on what it is that we're measuring when we look at our CB-CAPS technology. And I'll explain to you how those fit into the testing panels that we offer, such as our AVISE connective tissue disease test. But just by way of providing some of the clinical validation on these CB-CAPs, we've looked at both EC4D and BC4D in about 304 lupus patients that were enrolled in the Putterman study that's cited there down at the bottom of the page, or bottom of the slide. And when we look at these CB-CAP markers, we find that roughly half of lupus patients will have an elevated EC4D or BC4D. But when we look at these two biomarkers together, up to 2/3 of lupus patients have abnormally elevated cell-bound complement activation products, which significantly outperforms traditional complement C3, C4, which in the same cohort of lupus patients was below normal in about 44% of the lupus patients that were evaluated. In terms of specificity, we find that the CB-CAPs are rarely found in other autoimmune connective tissue diseases where a positive ANA is common. And so as part of our clinical validation, we set up the specificity of this assay against patients with primary Sjogren's disease, idiopathic inflammatory myositis, systemic sclerosis, RA, among other diseases that you see listed there down on the bottom of the slide, including ANCA-associated vasculitis and APS. And essentially what we found is that the CB-CAPs are about as specific for lupus as complement C3, C4. And against the normal healthy volunteer population, the test is 99% specific for lupus. So as much of a breakthrough as the CB-CAPS technology is, we still recognize the role for traditional autoantibody testing, such as ANA, anti-double-stranded DNA, and anti-Smith. And so what we do is with our AVISE lupus algorithm provided as part of every AVISE CTD test report, we combine our CB-CAPS technology with traditional autoantibody markers into an integrated result, which provides an index score between -5 and 3.5. When that index score comes back positive, the patient has an increased likelihood of lupus. And when that score comes back negative, the likelihood of lupus is diminished. And when we look at this integrated algorithm result that we've devised in our population of lupus patients, we find that 80% of them test either tier 1 or tier 2 positive on our algorithm. And when you compare this to the CB-CAPs by themselves, which I told you were found in about 2/3 of lupus patients, C3, C4, or anti-double-stranded DNA, the integrated result significantly outperforms your conventional diagnostic options when evaluating lupus. So now getting into the actual test offerings that we provide. Our leading test is the AVISE Connective Tissue Disease Test, which consists of two components. One, this AVISE lupus algorithm with a two-tiered assessment, as I just described, in addition to a host of autoantibodies that can be helpful in the differential diagnosis of lupus in working up and excluding potentially primary Sjogren's, systemic sclerosis, mixed connective tissue disease, rheumatoid arthritis, as well as autoimmune thyroid disease. And the AVISE CTD test is the only test that incorporates CB caps in addition to autoantibody testing for the differential diagnosis of lupus. On this slide, this highlights all of the biomarkers that are provided as a part of the AVISE CTD panel. As I mentioned, we measure the CB caps. We provide our integrated AVISE index result. And then we also test ANA both by ELISA and by indirect immunofluorescence using HEP2 cells. The anti-double-stranded DNA testing we provide is done through indirect immunofluorescence by Crithidia, which is the most specific method for detecting antibodies to dsDNA that are uniquely specific to lupus, and anti-Smith, which is also a highly specific marker for lupus. In our ENA panel, we have a host of antibodies here that are specific to primary Sjogren's in our SSB-LA antibodies, anti-Jo1, which associates with patients who have idiopathic inflammatory myositis like polymyositis or dermatomyositis. Our RNP assays, both UNRNP and RNP70, are highly sensitive for mixed connective tissue disease. And then with anti-SCL70 on through anti-RNA polymerase III antibodies, these three make up the most sensitive biomarkers for systemic sclerosis. And then actually we provide an RA panel which contains rheumatoid factors of both the IgM and IgA isotypes and anti-CCP antibodies. There's a panel of APS markers for anti-beta-2 glycoproteins and anti-cardiolipins, both because up to 40% of lupus patients will form these antibodies, but also for those patients who potentially might have primary APS. And then the thyroid panel is provided given the relatively high prevalence of autoimmune thyroid disease relative to lupus. Very frequently, you'll find patients who are ANA positive with just a positive thyroid antibody, and that can be helpful in ultimately ruling out autoimmune connective tissue disease and getting that patient on to endocrinology to have their underlying Hashimoto's or Graves' treated. There are two tests that are offered as optional add-ons. One is anti-histone antibodies for those patients where you might suspect drug-induced lupus, for a patient taking procainamide or hydralazine or minocycline, for example. We offer that as an optional so that you can use it where it's most clinically appropriate. And then the anti-CARP or carbamylated protein antibodies, which serve as prognostic risk factors in RA. Specifically, RA patients who exhibit anti-CARP antibodies tend to go on to have erosive joint damage more often than the patients who are anti-CARP negative, who also have RA. On this slide, we have a depiction of our AVISE CTD test results. And just by way of explanation, we provide our AVISE Lupus Index score, as I mentioned, at the top of every report, again, between -5 and 3.5. Anything that falls right around 0 is considered indeterminate, but as you go into the positive range, this is indicates an increased likelihood of lupus, and in the negative range indicates decreased likelihood of lupus. Now, just to explain our two-tiered analysis that we provide here, in tier 1, we evaluate biomarkers that are highly specific to lupus, specifically 97% specific for lupus. So if a patient has a positive anti-dsDNA confirmed by Clearfield, or an anti-Smith positive, or CB-CAPs in their strong positive range, where they are 99% specific for lupus, if any of those conditions are met, that triggers an automatic tier 1 positive result. And in our clinical validation, lupus patients were about 15 times more likely to test tier 1 positive than patients with other autoimmune connective tissue diseases. In tier 2, we weigh 8 different factors here, the ANA level, as well as the level of complement activation reflected in the CB-CAPs, EC40 and BC40, which serve as positive indicators of lupus as those levels rise. And that's counterbalanced by the presence of autoantibodies specific to non-lupus connective tissue disease, like anti-SSB-LA for Sjogren's, SCL70 for scleroderma, on down the list. And so if a patient is negative for all tier 1 markers, they'll be evaluated for tier 2, and that's where you'll get an index score plotted on this gradient, meant to illustrate an increasing likelihood of lupus as you move from left to right. On the back page of the report, this is where we provide the detailed breakdown of all of the autoantibody testing that we perform, grouped by disease association. As you can see here, this is a pretty traditional layout for a test report, where everything is aligned along the quantitative value and then the qualitative interpretation, as you see laid out here. In terms of clinical applications, the AVISE CTD test has been utilized by rheumatologists dating back to about 2012 is when this test was launched, about mid-year 2012. And over the years, we've had an opportunity to speak with a number of our providers about how and when they use the test as part of their normal workflow. And a couple of common points of utility come up. Naturally, those patients who are ANA positive with nonspecific symptoms of chronic autoimmune disease like malaise, unexplained weight loss, unexplained fever, arthralgias, etc. This is a good starting point because you're going to get your ANA testing done in addition to autoantibody testing that covers a pretty broad spectrum of autoimmune connective tissue disease. We also see the test utilized in these patients who may clinically appear to be more of a chronic pain type patient or fibromyalgia patient who happens to be ANA positive. It can be very helpful for a patient who may be convinced due to their positive ANA finding that they have lupus to show them a report where they have been tested not only for their ANA, but also the best set of biomarkers to help differential diagnosis of lupus and conclusively rule out autoimmune connective tissue disease when everything else comes back negative except for a positive ANA. We see more and more, especially during the pandemic, the test used for triaging patients who may be waiting to get in to see a rheumatologist or other specialist. This test can be used upfront to determine if a patient has any specific autoantibodies for lupus or potentially an abundance of complement activation that might warrant a more rapid referral than a patient who's simply ANA positive with no other specific findings. Lastly, given that we have a more sensitive diagnostic test for lupus, we also see the test utilized in these patients who may have previously been classified as undifferentiated connective tissue disease. We know from the literature that a relatively small percentage, but perhaps 10 to 15% of these patients with UCTD ultimately clinically evolve to lupus with time. And given our more sensitive biomarkers, you may detect abnormal complement activation sooner in these patients, facilitating their ultimate diagnosis of lupus sooner than they otherwise would with traditional testing. I spoke a little bit at the beginning of the talk about the extent of validation we've done on our revised CTD test. Initially, we evaluated the test in a multi-center clinical validation trial with nearly 800 patients. This is where we determined the performance characteristics of our test, that it is 80% sensitive and 86% specific for lupus against other autoimmune connective tissue diseases. And we separated out our normal healthy volunteers in the study. We found that the test is 97% specific for lupus against normal healthy population. Subsequent to that study, we've also looked at pediatric onset lupus and the differential there between pediatric lupus and juvenile idiopathic arthritis, showing that the test is essentially equivalently sensitive and specific as it is in the adult lupus population. We've also looked at the differential between lupus and primary fibromyalgia, with the test being 100% specific for lupus in that context. That is to say that we tested 75 primary fibromyalgia patients with our AVISE lupus algorithm, and none of them came up falsely positive. And then more recently, we published in A&R a prospective validation study where we took probable lupus patients, those patients who wouldn't meet classification criteria and therefore would not be eligible for a lupus drug trial, and looked at whether or not the AVISE algorithm could predict progression from probable to classifiable lupus. And indeed, that's exactly what we found, that those patients who are, those probable lupus patients who are AVISE index positive are about 3 times more likely to progress to classifiable lupus than the patients who test AVISE negative within an 18-month follow-up period. And this is just a snapshot of some of the studies we've done. This is a more complete list, which aligns each of the studies along the types of clinical evidence that we've developed. So we published an analytical validity paper in the Journal of Immunological Methods back in 2016. In this study, we showed the consistency of our testing results over a 2.5-year period, as well as showcased the robustness of our analytical methods. We have 2 clinical validation studies, which I've described for you, both the large study that established the initial performance characteristics, which were largely confirmed in the subsequent clinical validation study done by Ramsey Goldman and colleagues. And then we've done 3 clinical utility trials to evaluate the impact of AVISE testing on diagnostic conclusions and treatment initiation based on a positive AVISE result relative to a negative AVISE result, and how that compares to your standard of care approach. And the bottom line of these studies is that the increased performance characteristics, the sensitivity and specificity of the AVISE test translate into more accurate and actionable clinical decisions as a result when you compare that to standard diagnostics. And I believe with that, that brings us to the end of the presentation, and welcome any questions.
Are these tests done by Quest Lab or any other labs?
No. So the AVISE CTD is a proprietary lab offering from Exogen.
So how do we get it done then?
Perfect question. So I apologize, Jason. I said I was going to prepare a slide on this, but you can obtain information about.
Who made that the Panhandle's too expensive for hotels?
I'm sorry, what was the question?
I think we had some background noise there.
Oh, okay, yeah. So if you are interested in incorporating AVISE CTD testing as part of your clinical workflow, or just want to try out the test, you can obtain information on our website, either at exogen.com or avisetest.com. And We also have a provider relations number, which is our a primary conduit for interaction with physicians. This is a dedicated group that can help you set up the assay and connect you with your local representative. Jason is our representative in the Sacramento area, but we have a number of other representatives all through the US. So there's likely someone very close to you who can walk you through the process of our kits that we provide. Jason, do you want to talk a little bit about that? You can
Yeah,
explain better than me.
Sure. As Tyler mentioned, there's a couple of ways. I just handle the Sacramento, Reno, North Nevada area. So unless you're in that area, I'm not the right person to reach out to. But the provider relations number, if you want to write it down, if you're interested, is 888, or I can actually just text it into the, probably text it, but it's 888-452-1522. You can also go to avisetest.com, and there is a section for providers. It looks like Tyler's bringing that up now.
Yep.
Or maybe not. And you can get testing supplies and everything. So the test does require a blood draw. There's 2 tubes, a lavender and a tiger. Depending on where you are and what the logistical situation is for you. Ideally, if you draw blood in your office, this is a fantastic tool, as Tyler laid out all the different clinical applications. And if you can draw blood in your office, that's probably the easiest way for patients to get the test. Otherwise, we can send you the supplies, and patients can take the kit with them to any laboratory or hospital that'd be willing to do a pass-through specialty test. Little feedback there. Also, the cost is very reasonable. Exogen has done a pretty good job of minimizing the out-of-pocket costs to patients. And I'm happy to go over that, or your local representative can go over that with you as well.
And hopefully, if you can see my screen, this is the pertinent information that Jason was providing in our provider relations department that I was referring to. Or alternatively, if you prefer email, you can email info@exogen.com. Just let them know that you're interested in incorporating AVISE testing in your office, and they'll work with you to put you in contact with your local representative who can take your staff through the whole process. Fairly straightforward, as Jason said, 2 tubes of blood. We provide an all-inclusive kit that has a overnight shipping label, prepaid, and there's just a frozen ice pack that you have to throw in the freezer, and then throw it into the kit when you're ready to ship it out, typically through UPS, right, Jason?
Yes, that's correct. So I saw the question flash up. What's the out-of-pocket cost for a patient who wants to pay cash? There is an unofficial price for that. It's unofficial, but patients who want to pay cash pay $150, and that's basically per requisition. Like you get the whole shebang for that. Everything that Tyler spoke of. And then if you have insurance, it's significantly less than that.
What about discoid lupus? Can your test differentiate between discoid lupus and systemic lupus?
It would not differentiate specifically between lupus subtypes like discoid or lupus nephritis. Typically, that's really sort of clinical symptom-driven sort of diagnosis.
Well, Dr. Spear, do you have our resident rheumatologist have any comment on this? I know you're here. Okay. Okay, so we can get in touch with you. And slides are on our website, aosrd.org. Go to webinar. Question is clarify the usefulness for diagnosing Sjogren's.
Just by way of clarification on the question, are you asking about how our biomarkers can help with the diagnosis of Sjogren's? Is that the? Okay.
Answer, yeah. Question is, it responds yes.
Yes. So we offer anti-Ro testing, so both anti-Ro 52 and anti-Ro 60, which are sensitive and a part of, in fact, the classification criteria for Sjogren's syndrome. And we also offer anti-SSB or LA antibodies, which are less sensitive than the Ro antibodies, but much more specific for primary Sjogren's syndrome. Does that help answer the question?
I'm just relating. So 329-807. That says thank you.
Okay.
Okay. All right. I'm just the the ventriloquist here.
Yeah, no worries. I pulled up the chat so I can see it here now.
Okay. Anybody else have any questions, comments, concerns? Anybody have so I thought this was going back to our rheumatology roots, and that this was helpful for our group. We are beyond the basics in our group. We're most of us are doing something on the front lines with our heads hanging out there, ready to be chopped off by the traditionalists. So we want to thank you for your presentation, and I'll try to get the email addresses of everyone's here, or if you guys are here, if you can put it in the chat if you're interested in getting some more information for from Tyler and Jason. Like I said, we're still non-CME, so we can have you guys talk about your products. That was the other, I know I started out with an announcement earlier. That was the other announcement, as the AOA is developing a learning platform. And I've kind of volunteered this webinar to be their test subject for it. So when they get their stuff together, we will be provisionally offering CME credits for these Tuesday night webinars. For our guests, we're here every Tuesday night, 8 p.m. Eastern, 5 p.m. Pacific. We have had some of the leading lights in anti-aging medicine as part of our lecture series. In 2 weeks, Dr. Crowley, who's not here tonight, and I will be presenting a couple of cases. Next month, we have Dr. Pam Smith. She's the main teacher at the A4M, and she will be speaking about psoriasis and low-dose naltrexone. We still have a couple of weeks open. If anybody wishes to present anything, please let us know. And if anybody has any questions, comments, Dr. Halassa, are you there? You're usually awfully quiet tonight. So, and if not, Dr. Spear, I was hoping you.
I'm following up. Seems like very interesting presentation tonight.
Dr. Renz and Dr. Spear is our resident radiologist or rheumatologist. Any comments on the information that we saw tonight?
Thank you, Tyler.
Thank you, Tyler. And one last thing, David, I saw you there. Can you put your, David, if you put your, you're there.
Yes.
There was a June 1st, there was a change in the FDA's look at, biologics, the exosomes you
Right.
handle. Can you give us a little update on that? And,
Yes, yes, I can. Actually, the ruling on biologics in terms of stem cell therapy, both stem cells and later exosomes, was actually set in 2007. And in 2017, the FDA said, well, we're going to make clarification here. We'll give companies 3 years to get INDs filed and to register as drugs, IND, individual drug numbers. And everyone was aiming at that. There was delayed because of the whole period of COVID and all that. So they decided to make the new date, which was May 31st. And the decision basically is that they don't want to bother with PRP. PRP is, and they're claiming that they're going to mostly focus on the manufacturers, not the clinicians. But they said we can't ever guarantee that, how we're going to do our enforcement. But they're saying that basically either stem cells or exosomes are considered unapproved drugs, and they can be used as part of an IND for an IND. If it has a drug number, then you're only allowed to participate and recoup your costs only. Now, the gray area in this whole thing is that because PRP is still something they're not concerned with, there's a long aspects, whether it's something is autologous or they want to same as same. So the tissue area that everyone was covering under 351, 361, I don't want to get too complicated here, but 351 is considered cellular and manipulated, and that was always a drug in terms of tissue. 361 is acellular, not minimally manipulated, and that was considered a non-drug. Now they're looking at basically still the same, but they're looking at exosomes would be something which is considered cultured, or they want to look at it as a drug. And stem cells, it appears it's going to be the same. So they're saying they want to be supportive, but it looks like it's going to be more and more difficult. So the key for clinicians is in their marketing and advertising to not be talking about stem cells or exosomes at all, and to talk about regenerative medicine. And then in your communication with your patients, you can discuss about regenerative medicine. And then patient to patient, it can be part of a protocol that you want to use, but most companies are pursuing establishing an IND for research. So it's being sold as research. So that's a little bit of an overview. Maybe we can have a separate meeting where we can cover it in more detail.
hey, well, what are you doing next week?
Well, I've been joining these Patriot meetings every Tuesday. That's why I haven't been able to join you.
Okay,
So,
well, okay.
Actually,
All right.
I see Dr. Kalpana's here, and I know that she participated in the presentation. I don't know if she wants to make any comments on this.
Okay,
But
well,
anyway, yeah, so next week, yeah, possibly we can, maybe I can make an exception and attend.
yeah, it's really too bad. I had a great case just weeks ago, 94-year-old lady, compression fracture in her back's been in bed for 6 weeks.
Wow.
I'm actually doing ultrasound guided needling now. I have a portable that plugs into the iPhone. It's pretty neat. And we had an L2, L3, and L3, L4. put the exosomes right into the joint. You know, we got it right into the joint. And then I did the other unspeakable thing. I gave her 2 cc's. It was 100 billion. I gave her 2 cc's IV.
Mhm.
I did it on a week ago Friday night. On Sunday, I saw her in a supermarket shopping. 3 days later, 94 years old, compression fracture, hadn't been out of bed in 4 weeks. No, just
That's
unbelievable, just unbelievable results. And, you know, we get trashed for it.
Yeah,
Big-
well, you know, I think in that doctor-client, doctor-patient relationship, if we're careful and it's done under research, really the manufacturers have to be really, really on guard on how they're doing things. And they really want to see manufacturers being very careful in their procedures. But yeah, so, you know, it's one of these things where, while you guys have been doing great work, trying to work with limitations that FDA puts on the great work that, you know, integrative alternative physicians are doing. So, but between that patient and that doctor-patient relationship, I think we can still continue. I really, if you want to talk about what you're doing, you may want to talk a little bit about PRP, because it appears they're not going to be bothering with PRP.
Okay.
So,
Well, you know, and I don't know if you know this or not, but N-acetylcysteine is also on the hit list.
let's see.
N-acetylcysteine, you know, the precursor to glutathione.
Yeah.
Now decided it was considered a drug in 1963, and Amazon's taken it off of all of their over-the-counter supplements. And yeah, so there seems to be, Dr. Halassa, there seems to be a common theme of all these things that seem to be in the radar of those who know better. Not being the conspiracy theorist, I won't spell it out, but I'll just leave it up to the group to think about that. Okay, anybody? Thank you, Tyler. It was a great presentation. Your slide deck is on our website. We're recording it. If it works, I'll put that up there also. Sometimes they don't work out so well. So, Jason, thank you also for arranging for have your company give us this presentation. I think this is probably some new information for a lot of us. Anybody have any questions, comments, concerns? We're done a little early tonight. Usually we go a little bit.
I would just say if you think that this tool can help you with some of your patients you suspect with autoimmune disease, make sure Dr. Clearfield has your email address. And Dr. Clearfield, do you want to send me the email addresses? I can have the local representatives follow up.
I'll send you what I have. Okay.
Great. Have a good night.
All right. Thank you all. Next week, same time, same station, and we'll have another exciting episode of rheumatologists at large, roaming at large. Okay, so thank you all. Get to go home early tonight, and have a great night.
Thanks, Bill.
Thank you all.